Ladies and gentlemen, good morning to everybody. Guten Morgen, buen dia, ni hao, whatever you want. It's a wonderful morning in Florida, and I want to introduce to you the morning session with outstanding keynote speakers. I prepared, you know, we Germans love soccer, and I prepared a little card for the speakers, so it means 3 minutes left, 1 sentence left, and please take care about the time. Okay, so the first speaker I want to introduce. The first speaker is already prepared. It is, let me see, a very long bio, but Maureen Lucy Schafer received her PhD in Healthcare Systems and Informatics from the University of Arizona. Dr. Schafer possesses a comprehensive background in advanced clinical care, healthcare systems, teaching, and expert applications in the systems lifecycle model. Well, she asked me to shorten a little bit her short bio, but I think it is valuable to pronounce that Dr. Schafer is passionate about sharing knowledge and is an adjunct professor teaching across the curriculum in the Health Systems Administration Department at Georgetown University, Washington, D.C. So it is your microphone.
Good morning, all. It's great to be here. I was very excited when I saw this conference and what it was about. It really connected with me because you never know where life is going to take you on a journey. I was an Army soldier for 25 years. When I retired, I wanted to know about academia. What is it about academia? And so went full-time into academia for 4 years and then missed the application and kept one foot in, and then now I am full-time working for the Department of Defense as a clinical informatics SME. But one thing I saw was that incredible collaboration. What I learned from my mentors and peers in academia and in industry was an incredible impact that you can have the more we merge those two worlds together. Just a disclaimer that I need to present. So background, this is what I'm passionate about as starting in healthcare as a young nurse, that healthcare systems should provide an interweaving framework of people, physical structures, and electronic systems to support best practices. And as I traveled around the world with different assignments, either as an Army soldier or in the civilian, it seemed to change from one organization to the next. And I've heard this in different domains. And when we do clinical care, we're very big on clinical practice guidelines, but often the system that we house it in is not a best practice system. And it's what I call thought leadership, often. It happens, and at the user level, it can create a lot of frustration. There's a lack of standardization. It's difficult. We become masters at workaround, and the biggest thing for the stakeholders too is how are we measuring this? So, is it a question of industry versus academia? There are people that have perfected this relationship. Often though, when we think about a program project manager, they have 6, 7 different devices. They're running a marathon every day. Just go, 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 output after output. Versus often people think of academia in that white tower, covered with books, lots of time to do thought process. So these images kind of come to mind. I, in my view, don't believe it's a versus at all. I think it's understanding the contextual differences, which is the most important part of any system. What is the context? You know, are we in Orlando? Whoops. Do I need to? Can everyone hear me now? Thank you. So it's understanding those contextual differences, which is the most important part of any system, from industry over to academia. So people have connected those. Generally, though, on the industry side, when we look at 94% of healthcare systems failing, that thinking is siloed. We need to dip into academia, and we need to use those theoretical models. We need to use those best practices and valid and reliable metrics. So how do we get to that impact? So knowledge sharing is going to be that common denominator. And when you look in the literature at knowledge sharing, what they speak about is a term that showed up in the literature in 1994 called knowledge stickiness. And you want enough stickiness so that the knowledge stays where you grow it, but that it also can transfer somewhere else. So in an organization, perhaps in an outpatient clinic, I put a process in place. I want that knowledge to stay, but I still want it to be a low knowledge stickiness so that I can share it across the other systems, across the continuum. And nowadays, it's the grouping of people, processes, and technology. So what is the role model that we have for knowledge stickiness? There it is. This is the role model. Spider-Man, so superhero. But we don't need to be superheroes if we're working as a team. But when you think of the traits of Spider-Man, here are some of them. So risk shooters, a strong materials, a great intellect, a proficient scientist and inventor, has strength, speed, durability, and agility, able to cling to most services, and has that spidey sense. So how does this equate in real time? So here's the risk shooters I met when I showed up into academia. Dr. Efkin, Dr. Ryung Soo, Dr. Kate Cressy, automatically shot out their wrist. Hello, Maureen. And I have stayed in touch, and these are how it's networking is everything. We share ideas, and it helps each of us grow. Often when I'm working on a project, I'll reach out to somebody in academia who's been in there a long time and just say, hey, here's where I'm thinking, how's this conceptual model look? Or I'll bring them in, and because we also want them to leave academia and to see what's happening. And some of the challenges, often if you're not in those working lanes, it's hard to see what you have to overcome, and making sure that you speak to that user on the ground. So what I did with this was I took the combined intellect to generate some ideas on a course, and these were the learning objectives I created. And I started with a group of graduate students looking at the impact of data, information, and knowledge, applying those theoretical and conceptual models to a real-time system problem. In fact, this week, my students at Georgetown are on what I call a field assignment. They're going across into the healthcare systems, and I let them pick any area they want. I have students in the emergency department, and we're in the Washington, D.C. area, so I help them network and find somebody that, how would you like some graduate students? I put them in groups of 3 or 4 to work on these projects, and it's been fantastic. They actually connect with the stakeholders, get their buy-in, and they work in real time with the users. So following these objectives, they have to apply a formative method, and and the resources can vary depending on what they're working on. I have one group working on an outpatient project, so they're speaking to the chief of that clinic, they're connecting with IT. I have another one working with oncology and patient education, so they're speaking to some of the patients, the users. How are you finding that education for what you need? Trying to get through this process. Also timeline with each step. So it is that scientist and innovator, that perfect balance of academia and industry. I use the systems life cycle. It's borrowed by healthcare information. It's been out in the field. Computer science engineers have used it for years. And the students really connect with this because it's a stair-step model. And what I did for each step, I produced worksheets where I combined academia and industry best practices. So on one hand, I say, create a chart with all the evidence-based problems, evidence-based literature that supports your problem. Okay, so you're telling me that barcoding is not effective. Okay, find the literature on barcoding and what works. Or why is the telemedicine equipment sitting in the corner of the ER? Let's pull out best practices for implementation with telemedicine. So I created these worksheets for each of these. On the undergraduate level, they get about through the first 2 steps, which is appropriate. On the graduate level, I have them up to implement. And then beyond that, they need to take another semester where we work through that implementation process. So where does the rigor, timeline, and agility come in? Again, that balance of industry and academia. On one side is the Gantt chart, which is a project management tool. And there's some fantastic tools that match with what we do in academia. But we match it with the scientific research findings, and our Gantt chart can move. We can adjust the timeline. We include the stakeholders' values and concerns. And they may say, you know, I want the scope even more limited. And then that professional experience and judgment. Industry, typically those consultants have come up through the system. But they may have come up through thought leadership, and that's why they need academia. But in both worlds, we need somebody that's open to that experience, to work together. I met 2 gentlemen yesterday who said they are looking for that relationship with academia and have not found that person. Sometimes they're dismissed as, well, you work in industry, you wouldn't understand what we're doing. But that's not the point. The point is academia wants that research off the shelves. They want that evidence-based in there because right now for healthcare, it's taking 17 years from the time that new evidence-based practice comes out till it hits us in our healthcare system. That's problematic. So if we can merge these 2 domains together, it's better in the end for the patient. And we've all been in different healthcare systems, so we want that evidence-based practice. So here I wanted just to chat about some of the projects that student groups I've worked with over the years, just to highlight one, the power of industry and academia and using a theoretical-based approach to it and tying in those project management tools. So Medibabble is free software. It was created by a group of actually 2 residents. I'm not going to say the school because I might have that wrong, but from California. And they worked with a lot of patients that spoke different languages, and the translators often didn't understand the clinical terminology. So these 2 physicians created the software. It's absolutely free. You can download it on your phone. They have 7 languages now. They take user feedback from across all users. So you can send them their ideas. And why this is so effective, it keeps that relationship between the provider and the patient. And the system life cycle that the students did was we had 7 free clinics that we were working in across Northern Virginia and a very diverse immigration. And oftentimes because English wasn't a first language, we were having difficulty. So what they did was an implementation of Metababble, one that would stick, that knowledge stickiness. So they did a whole project where the students were oriented, they had Metababble downloaded on their phones, and then it was passed on. So that's that knowledge stickiness. Enough to hold, but it keeps sharing. Different arena in healthcare, GlycoMaster. This was in the intensive care unit in a large healthcare organization. Anyone that is familiar with diabetes, it's a very kind of tedious sliding scale that physicians write. So if the patient's glucose is here, you give this amount of insulin. And physicians develop their own sliding scale, and it's very subjective to that patient. This software for patients in the ICU automatically detected the glucose and administered the correct dose of insulin. Incredible software, valid, reliable. So they implemented it at the healthcare organization, spent months training the nurses that were working in there. They left out an important user group. They left out the physicians. And the physicians didn't want to use it. They didn't trust it. So what our team of graduate students went in, they kind of started from ground one. They used the systems lifecycle model and pulled in those physicians and the nurses together. And the most difficult thing I have found with students is they want to skip steps on the system lifecycle. They want to go, I know the solution. We're going to write a policy and mandate those physicians do this. And I said, just stay with the life cycle, because it will work its way through. And sometimes you don't know where that problem is going to show up or the area you need to work on. Outpatient check-in. This was a very interesting issue. So it was a large outpatient clinic, and patients were getting lost for 2 or 3 hours in the outpatient. So think of yourself as a patient going through the system. You get back in the room, you're excited, it's going to happen, I'm going to see my doctor, and then you're there 1 hour, 2 hours. Meanwhile, your physician's like, where's my patient? So what was happening is 2 systems were being followed. The administrators would check in some of the patients electronically. Some of the nursing staff would grab patients out of the waiting room and just put them in a room and write the room number on a whiteboard. So that silo creation. So the importance that highlights here is going through that system life cycle, is drawing that process map and then showing the staff what's happening is, hey, you have a good system here with the administrators, but it wasn't until that process map was drawn out that they were able to see that, and we were able to, one, for the safety of patients, keep it into one system. Telemedicine in the emergency department, this was a passionate group, and one of the students had lost her brother to the opiate crisis, and he had sought help in an emergency room. And the difficulty was many emergency department providers are not trained as mental health care providers, and it's time intensive. And I think the tragedy in this was they had telemedicine equipment in their ER. But we went in, we did an as-is system look and walk through, and again, it was no one had trained these physicians on it, but also there was no one on the other end. So we pulled in the mental health department, and they created a call roster. So when they had patients, and it was very diverse from depression to maybe having an opiate crisis, they were able to put them in with the provider and pull up that psychologist or psychiatrist on the telemedicine. Very, very successful and very helpful to many patients, as well as it didn't pull the emergency doc away from those patients presenting with trauma. Supply chain. They had no way to, they wasted about $5 to $6 million a year in supplies because once they expired, they tossed them. They had no way to track them. So here was a simple barcoding solution. But again, followed the system's life cycle, looked at it, and figured out what they needed to do. This last one is, students are working on this week, is the patient portal. So at a student health clinic, there's a portal button, but it's a portal button to nowhere. It doesn't connect. They go round in circles. When the students present to a health clinic, it's the administrators asking them in a room full of people, why are you here? What's your problem? So there's HIPAA, ethical issues, as well as patient safety. So one of the things I tell them, aim small, miss small. So just start small, because the point of all this is just to understand the system's life cycle model, and you can move to that enterprise level later. So where's the spidey sense come out of this? So the data, information, knowledge, wisdom, that continuum is so powerful. The more we can get combined data in a seamless way, we provide meaning. Okay, I see this information, it's meaningful. And then that knowledge and action, where the clinician can come in and look at it and know how to act on that. So it's knowing what comes next, is that knowledge and wisdom, and that sense of, okay, I have a system that's going to bring all the data I need to help me make a good recommendation for this patient. And of course, experience. It takes 10 years per the literature to become an expert in anything, no matter what your domain. And those are the people that you see them all the time. They stand in the doorway, wise, and they can assess the situation quickly. It's all that knowledge and action. But it's that sharing at the end, and that's what we want to do between academia and industry. So in conclusion, knowledge, stickiness equates to knowledge sharing. And the best way I feel to do this is take these project management ideas and thread them with validated and evidence-based practices. I've seen it work. We've gone back and looked at these projects done by students, and it's been very successful. The fact that we're asked back to these different healthcare organizations around DC is very powerful for us. And I don't know if we're doing, thank you so much. Are we doing questions now? Okay. Okay.